Okay, so like I said, this is just a review paper, just kind of the brief overview of treatment of ARDS with prone positioning. So basically proning is obviously turning the patient from the supine position that we normally see them laying on their back to prone on their stomach. First introduced in the 70s is kind of a method to improve gas exchange in patients with ARDS. Catherine just gave a great little talk about ARDS. So, 170,000 cases annually. Mortality can be 25 to 40%. So the theory about prone positioning is that by flipping the patient over, we can reduce that pleural pressure gradient and restore aeration to the dorsal lung segments. And then the question kind of moves to, there are these known physiologic improvements, but is there really a mortality benefit? And for a while, that was really a big question. So in terms of supine positioning, just at baseline, we have our dorsal pleural pressure when supine. It's increased by the weight of the front of the lungs, the ventral lungs, the heart, and the abdominal viscera, all pressing down on the dorsal lung segments. So this compression, actually it increases the transpulmonary, pressure in the dorsal lung region. And the increased mass of these spongy edematous ARDS lungs also reduces that regional ventilation of the back of the lung. So the weight of the ventral heart and the intra-abdominal pressure, it further compresses that dorsal region and it decreases perfusion. So all of these factors compress the dorsal region while the gravitational gradient of perfusion, it perfuses the region. So it causes that low ventilation, high perfusion combination, which results in hypoxemia. So by proning, it reduces that pleural pressure gradient through the gravitational effects and the geometric conformational changes of the lung within the chest cavity, which results in the more homogeneous lung aeration and strain distribution. And this geometry favors the more equitable aeration distribution. So this is kind of just a little figure from the paper that shows that the gravity in supine positioning, it really it compresses that dependent dorsal aspect of the lung, resulting in a decreased total surface for ventilation and perfusion. Whereas by proning, you can see that the dorsal aspect of the lung is able to open up more, causing less conformational changes, or like the compression of the anterior segment, which results in more expansion and increased capacity for aeration. And the physiology and the studies have shown that it really does support the theory that the prone positioning, it promotes this homogeneous aeration and conformational changes. And the CT data shows that the lung shape asymmetry causes greater pleural pressure gradients when supine compared to prone, just based on the shape of the lung and the mechanics of the lung and forces. But we needed, the further studies, they showed improved homogeneity of the aeration and ventilation when prone. And these are all just the physiologic findings, so not necessarily correlated with any clinical improvements at this point. So proning does not have a major impact on the regional distribution of the pulmonary blood flow, which is actually directed dorsally in the normal and ARDS injured lungs. And this regional perfusion distribution is dictated by the non-gravitational forces, so kind of regardless of proning or supine. So if perfusion is constant and ventilation increases, the shunt fraction will fall with prone positioning. So that just being the amount of blood being shunted to poorly ventilated areas, causing less perfusion. So multiple human and animal studies have confirmed that the hypothesis of proning improving oxygenation is true, and that proning, it decreases that shunt fraction by about 30%. So in most patients, decreased shunting when prone leads to clinically significant improvements in oxygenation. So we've seen that the proning does improve oxygenation, but it's thought that the ability to attenuate the mechanical lung injury may be more important than the oxygenation benefit. So the major clinical trials have all shown that there is an improved oxygenation, but only the ProSiva trial really reduced mortality and vent days. I didn't go too much into the ProSiva trial. I can talk about it a little bit as we go on, but it was a really good study that Catherine hit on as well. So in terms of lung protection, this is kind of an important point. Sorry, 1 second. That how does the proning really reduce the ventilator induced lung injury? So it improves the dependent aeration, and that recruits the parenchyma, so the white arrows on the graph here in the column 3 from that previous graph. So you can see here the white arrows. So here's the supine, here's prone. So you can see from the dorsal to ventral, and the tissue to gas ratio on CT, that's really just the you can think of it as the pulmonary aeration. So when you're supine, you have this really big kind of difference, this change in the aeration. And when you prone them, you see how the aeration actually improves and the overall width decreases. And then it also causes, by proning, a reduction in the hyperinflation, which is the black arrow. You can see how when supine, it's increased pretty far, and that by proning, you decrease it, and it's more in line with the lesser end of that spectrum. So, right, so that just kind of shows here, and that the net effect is that there's more homogeneous aeration, less extremes, and this reduces the regional shear forces and shear strains that lead to the ventilator associated or ventilator induced lung injury, which is protective from, you know, the inflammation and the fluid accumulation that we see in ARDS. So prone positioning and high PEEP ventilation may have complementary benefits, and Catherine hit on this as well, why we want to utilize high PEEP strategies to keep the alveoli open, which prevents the collapsing and reopening, which leads to the ventilator induced lung injury. So in ARDS, you have this increased PEEP, and it's known to prevent the alveolar derecruitment or collapse, but this may also promote the overdistension of the previously well-perfused alveoli. So adding proning to high PEEP ventilation, it further increases the lung aeration while also reducing the regional hyperinflation and decreasing the small airway opening and closing events. So proning may decrease these barotraumas and atelectraumas, thereby protecting against VILI. So other benefits, kind of just minor compared to the ventilatory effects, but there may be reduced infectious complications with proning. So in pig models, the tracheal position actually being relatively anterior to the lungs decrease the incidence of ventilator-associated pneumonias. And while prone, gravity also can assist in secretion drainage, which may explain observations they've seen in studies that there's improved secretion clearance, opacities migrating ventrally on imaging, and decreased rate of the vent-associated pneumonias. There's also some extrapulmonary effects. So the total cardiac output is unchanged, but when prone, the right atrium moves ventrally, which causes the venous return to be aided by gravity, causing, so because of that, the preload responsive patients may actually have augmented cardiac output by proning. And the right ventricular afterload typically falls, likely due to the relief of the hypoxic pulmonary vasoconstriction. So the proning reduces the right ventricular dilation and septal dysfunction that is seen in severe ARDS. Just some other extrapulmonary effects. Obesity is known to worsen dependent dorsal atelectasis, and proning improves oxygenation in obese patients. But in obese patients with ARDS, the proning may worsen their intra-abdominal hypertension and lead to renal and hepatic dysfunction. There's also an increased risk of vomiting and decreased tolerance of high volume enteral feeding. So you need to really closely monitor residuals and keep a patient kind of in a reverse Trendelenburg position. So the physiologic effects of proning are well described, but the clinical trials have really been mixed, regarding the clinical benefit. So the Gurin et al. ProSiva trial was really the only trial to show a mortality benefit. But the reasons for this may have been kind of complex. The Perceiver trial goes into explaining it in a little more detail, but there was a limited sample size, a lot of crossover, not really any standardization of the vent management. They were using high tidal volumes, which we know now is associated with greater mortality compared to low tidal volumes. Inclusion of patients with only mild ARDS. Proning is more beneficial in patients with severe ARDS at baseline. A small dose of time in prone positioning. The Perceiver trial and subsequent meta-analyses have shown that you really need a high dose of prone positioning over 16 hours per day to really see any clinical benefit. And then there are also these arbitrary criteria for the cessation of proning, which wasn't standardized among the previous trials, and enrollment of patients late in their disease course. And the Perceiver trial also goes into talking about how proning shouldn't be really seen as a rescue strategy or a last-ditch effort. It should be used early within the disease course to help prevent the, progression of the ARDS to being a rescue maneuver. So clinical trial evidence suggests that to achieve these improved survival with proning, you need to, okay, sorry, got a little ahead of myself. You need the patients with severe ARDS at baseline, long duration, more than 16 hours per day. You need to have set physiologically driven criteria for the cessation of proning, concurrent use of lung protective therapies, and experienced staff able to minimize risks, which there are, significant risks with proning patients. So in terms of that, practical considerations, so the 2016 Lung Safe study found that only 16% of patients with severe ARDS were treated with proning, and that may be due to these perceived logistical difficulties, which can contribute to poor implementation, because it can be difficult. We've all seen our patients in the ICU with all, their central lines, and they're intubated with, it's not a small undertaking to take these patients and flip them over, a few times per day, at least if you're prone 16 hours, that's, twice a day, turning this patient. That being said, it can be safely done and is safely done at certain centers where they do this regularly. You need at least 3 to 4 staff members to do it safely. One member is dedicated solely to endotracheal tube management. Of note, there's often increased secretions immediately after proning, which require someone to kind of be in the room, stay with them, and suction. But once that initial secretions resolves, it actually moves more toward being less overall. And then once prone, you need to pay attention to preventing pressure ulcers and tube obstruction and dislodgement. So when do we revert back? There are Perceiver criteria listed out in the Perceiver trial that they used. And although they're useful, the optimal duration isn't really well documented or well understood. And that being said, supinating prematurely can lead to de-recruitment and potentially worsen villi, the ventilator-associated lung injury. So the paper, the review article, recommends continuing proning until the clinical variables are sustained improvement. And further studies are needed to identify optimal criteria. Some contraindications would be severe facial or neck trauma, pelvic or spinal instability, elevated ICPs, which again, this is more of the medical side. Obviously in our trauma ICU, we see more patients with head injuries. So we have a lot of patients that we monitor ICPs, which is, so just something to keep in mind. Hemoptysis, frequent cardiac arrhythmias, and the high probability of needing CPR. Interestingly, regarding that, the Perceiver trial did note that one of their secondary endpoints was that patients who were prone actually needed CPR less than the patients who were left supine. Whether that was a factor of being prone or not is, I guess, questionable. And so although experienced centers, they have reported using proning in extreme cases like those above, patients in their third trimester of pregnancy, patients on ECMO, and patients who do have invasive ICP monitoring. So just the paper gave a table of recommendations: when to prone, how long, what position, and when to stop. And these are the Perceiver recommendations that if we have this recorded, or I can send it out if you want to peruse it, the paper as well. And then further studies need to emulate the extended duration and low tidal volume approach that's supposed to be used to really nail down these recommendations. So what is the optimal approach to PEEP management and prone positioning, and is it effective in patients undergoing high PEEP strategy? Does the proning necessitate neuromuscular blocking for 7 days? And does that contribute to the neuromyopathy that Catherine hit on and the functional impairment in survivors? Is it only effective in the subset of patient with ARDS? And how can we better clarify what populations can benefit the most? And what's the learning curve for adopting proning in centers that don't routinely use it? So just kind of in conclusion, recognized for the ability to improve oxygenation, and it has historically been used as more of a salvage measure for refractory hypoxemia. But recent studies have shown that in select patients with severe ARDS, early in the course, as opposed to a rescue maneuver, it can improve survival. The survival benefit is likely mediated by reduced lung injury due to minimized regional differences in the lung aeration, compliance, and shear strain. It may be underused in clinical practice currently, and if used, it should be used early with experienced staff for an extended duration.